Next speaker is Stuti Chakraborty. Stuti is currently working at Christian Medical College, Valera, and she's a country representative for healthcare information for all. Her work is part of SDG 3. She's also engaged in a lot of other teams, associations. In addition, she runs her own nonprofit initiative. It's called Stimulus. They aim to raise awareness about the brain senses and tackle ableism. That's very impressive. And you can also get in touch with Stuti on LinkedIn. Please do find more information on her in the chat. Thanks very much. Please go ahead, Stuti.
Thank you for the introduction. Hello, everyone. Good evening, good morning, depending on whichever part of the world you're in. Am I audible to everyone?
Yes, very good.
Okay, great. Before I begin, I do not have a presentation, but I have a poster and I will be presenting my screen. So I would just like to explain the background of the work that I do. I'm an occupational therapist by profession, and I work in a rehabilitation setup. And I'm mainly involved in the rehabilitation and treatment and clinical management of patients with stroke and different types of neurological disorders. Mainly, the most common ones we see are stroke or cerebral vascular accident, MCA strokes being the most common ones. And apart from that, we also see a lot of clients with road traffic accidents that have deficits in their visual, spatial, perceptual skills, their different higher cognitive and executive functioning abilities, as well as their motor function. So the study that I have done is to develop an assessment tool to find out the deficit in their motor and their process skills. So as an individual who can function normally, when all parts of the brain are intact, there are skills for doing any self-care or daily activity of living, which is anything that includes our starting from our morning routine to what we do at night, and our occupation, as our role, whether it is us working in a lab, whether it is doing research, whether it is doing teaching at a university, whether it's working at in a university or in a hospital. All these come under our roles and our occupations that we need to perform in our day-to-day lives. So when a person has an injury in the brain, these get affected. And the two ways that we can classify how an injury or the extent of the injury can impact a person's day-to-day routines can be in the form of the motor functioning and the process functioning. So if I take a very simple task like brushing our teeth, it seems like a very normal procedural routine that occurs when we do not have an injury to the brain. But when there is an injury to the brain, especially in terms of an injury to the frontal lobe or an injury to the parietal lobe, where the visual, spatial, or the motor function might be affected, there are deficits in the motor skills and process skills. So if we take the task of brushing, it actually, we do not really think about it, but it actually requires a lot of processing that goes behind in terms of paying attention to where the brush is, paying attention to where the toothpaste is, applying the toothpaste on the brush, taking it to the mouth, and then moving it around the mouth. So all this requires a lot of sequencing. It requires a lot of attention. It requires a lot of understanding about the different processes that are going on inside one's mind. And when it comes to the motor, it requires you to reach for the brush. It requires you to grab the brush. It requires you to manipulate the toothpaste and open the toothpaste. So all these things are very, very important. So I'm going to go right into my study, and I'm going to share my screen. So the name of my study is to develop and design and validate the functional, motor, and process skill scale, which is called as the FUMPS, among persons with acquired brain injury. So acquired brain injury can involve anything, whether that is stroke or whether that is a head injury. So as you can see, the definition of acquired brain injury can be anything which has a rapid onset of damage to the brain because of multiple causes, including but not limited to trauma or post-surgical drainage, CVA, anoxia, toxic metabolic diseases or subarachnoid hemorrhage, or even different types of infections like meningitis or encephalitis. So the aim and objectives of my study, as I mentioned, was to design and validate a scale to assess the extent of damage in the process and the motor skills of a person with acquired brain injury. Why is there a need to develop this assessment scale? So as an occupational therapist, there are different rehabilitation professionals involved in the treatment of people with injuries to the brain, like physical therapists, occupational therapists, speech pathologists. There is a physical medicine and rehabilitation physician. There is a rehabilitation nurse. So there are a lot of individual rehabilitation professionals that are involved. But specific to the role of an occupational therapist, we really focus on the functionality or the functioning of the patient and their ability to carry out their day-to-day activities and occupations, as I mentioned at the beginning of my introduction. So it was very important to develop an assessment tool that is currently not available in literature, specifically for the Indian context, because in a country like India, which is very large and diverse, and the country that I am from, it is very difficult to adopt a westernized tool, which is from a Western country or from an Eastern country, which is culturally very different from the practices that are present in India in terms of the day-to-day occupations of people. And by occupation, I do not mean a job. By occupation, I mean the day-to-day activities that a person might have to do, whether it's brushing their teeth or whether it is teaching at the university or doing lab-related work. So it was very, very important to develop such a tool to assess it specifically in the Indian setting and context. So that is why we thought of developing a tool which will assess the extent of damage to the motor and the process skill for performing each task. So just to give an introduction of the tool, it consists of different activities, starting from some examples of which are brushing, eating your own food. That includes opening a packet of biscuit and taking it to the mouth. And then also includes wearing a shirt or a t-shirt, also includes wearing a pant or a lower half dress, and it's very diverse in different parts of India because it's a very culturally diverse country. Then it also includes sending an email. It also includes gardening. It also includes changing the bed sheets for a particular person's bed. It includes cutting and chopping vegetables. So all these activities which occur in our daily lives might seem very generalized to us, but when there's an injury to a person, like I mentioned, the motor and the process skills for performing each of these activities get affected. So the first objective of my study was to design the functional motor and process skills scale, and the second one was to find the test retest and the iterator reliability, and the third one was to find the concurrent validity with the existing scales. So the study involved two phases. The first phase was to develop and examine and choose the appropriate tasks, which are, like I mentioned, completely which are in concurrence with the entire population of India, because India is very diverse. So we developed these particular set of tasks from the ICF core sets for acquired brain injury, which is the International Classification of Functioning, Disability, and Health. We developed it on the basis of the ICF core sets. Once the tasks were chosen, it comprised of instrumental activities of daily living and basic activities of daily living. Instrumental activities of daily living are basically associated with the individual's environment, and basic activities of daily living are associated with one's own self. That is the activities that they have to do for taking care of their own self. So it consisted of first making the tool, the second step, and then it was modified and it was sent to a panel of experts for getting feedback. And then it was given for validation, that is item validation for expert opinion. And the second phase was to standardize the tool, wherein I assessed the concurrent validity and the iterator and test retest reliability. So in terms of the concurrent validity, we compared it to two currently existing tools, which are there in literature and which are widely used in rehabilitation, specifically in India. One is the Montreal Cognitive Assessment, which is a short cognitive assessment, which consists of a total of 30 points. And it requires one to assess different deficits in cognition. That includes, it has different domains like attention, memory, then there's a little bit of visual spatial as well, and then language components. So it's a very comprehensive assessment which can be performed rapidly, and it is a lot more shorter than the ACE, which is the Edinburgh's cognitive examination. So I compared the process component, which had to do with the cognition aspect of doing a task, with the MOCA, and I compared the motor component, which has to do with the physical or the motor functionality of performing a particular task, with something called as COVS. The COVS is also, again, widely used in rehabilitation by physical therapists. And coming to the results, there were 25 patients recruited. Before COVID started, the study was done, and samples have been completed up to 25. There are 49 samples, so I have around 26 more samples to complete. So the analysis was done at 25 samples. You can see the gender representation and the diagnosis representation. So coming to the results, it was found that the Cronbach's alpha and intercross correlation was very high for rater 1 and rater 2, that is for inter-rater reliability, for motor, as well as for both process skills. And for retest reliability, that is, it was done in within a period of 2 days to maximum of 4 days or 5 days, but not a week, because in rehabilitation we set goals according to weekly basis. So there is a very high chance that the patient might proceed to a new level or a higher level within a week. So we had to restrict to below a week. And this was done for the motor and the process. And you can see that again, there was a high Cronbach alpha and intercross correlation. Then the correlation between MOCA and process score is found to be 0.83, which is a good correlation. And the correlation between COVS and a motor score was found to be 0.78, which is a moderate correlation. So based on this, one thing that I forgot to mention is that this was an extremely, so I'm going to stop sharing my screen now. So one thing I would like to mention was that this was a very function-based tool, because the MOCA and the COVS are they're assessments or tools which are extremely paper and pen-based or tabletop assessment-based. And so the reason why this tool was developed was to get an idea about what the patient's current or the client's current level of functioning is. So in rehabilitation, it's very important that we make the client perform the activity or perform the task at hand and then assess it, rather than just ask them a couple of questions like what is today's date or day, or what is 100 minus 93, and to find out their deficits in attention and orientation. So this is a more comprehensive and function-based tool, as I mentioned, and we finished 25 patients from different parts of India, and we found quite high correlation. The low correlation with the COVS, or I would not say low, but the moderate correlation with the COVS was because the motor component is extremely functional. However, for the COVS, it just requires the patient, some of the standard things that are performed is to ask the patient to roll to either sides of the patient. It also requires the patient to stand up, get up from the bed, and just general tasks. However, for the motor component for my tool, I asked the patient to categorically perform tasks and then score them on the basis of that. The rater 1 was done by me, and the rater 2 scoring was done by the patient's individual therapist. And the feedback that we got from each therapist was it was quite an easy to score scale, because it was on the basis of 0, 1, 2, which is 0, where 0 stood for not performing at all. The scale is not performed at all. 1 stood for partial performance, and 2 stood for complete performance. So it was quite easy to score as compared to other tools where there's a very comprehensive and extensive scoring list which is available. And apart from that, therapists also reported that it was easy to understand, and based on the difficulties that the patients found out, they were able to plan their treatment according to that. So the plan is now to complete the sample size and move ahead to a phase of standardization, where it can be standardized on around at least 200 more clients, and then it can be readily available for usage for rehabilitation professionals in India, as well as different other parts of the world as well. Okay, so I think I'm going to stop there. I think you're muted, Gaiqing.
Okay, thanks very much, Stuti, for your wonderful talk. It's very impressive, and I think it's very, very useful. And it's also very challenging too. So let me see if we have questions in the chat. Okay, so far we don't have questions coming out yet. Can I ask a question? Maybe I just missed a part. So as India is very diverse culture country. So how to validate the assessment across the country? Can you explain more about that?
That's a good question. So the reason why we chose a set of tasks, like I mentioned, we had a look at the ICF core set for acquired brain injury, and we picked the most relevant ones. And we didn't, and to make sure that it was not biased, we also sent it to a panel of experts, which consisted of an occupational therapist, a physical therapist, a physician that deals with rehabilitation, and also a psychologist that gave their feedback and review. And they had representation from different parts of India and also combined experience in rehabilitation. And so after receiving the feedback from them, we chose a set of tasks which are most appropriate and most relevant and applicable to all Indians. So I'm just going to turn off my camera for a while, and I'm going to take up the scale and show it, if that's all right.
Mm-hmm. Go ahead.
So I'm going to share my screen again.
Mm-hmm. Mm-hmm.
So as you can see,
Mm-hmm.
this is neurobehavioral. So this is a task which consists of brushing, combing, wearing a t-shirt or a top, wearing a pant, tying a sari. So sari is actually a traditional attire that many women in India wear. So again, it's very context specific to India. Washing face, opening and eating a packet of biscuit, taking the medicine, folding a shirt, making a list and buying them from the shop or the store, making a phone call, preparing a tea or a coffee, preparing an omelette, preparing a veg or non-veg curry. Yeah, so you can see the rest of them. So these are to do with the daily activities as well as the activities that many Indian women do or many Indian men might do. So just to give an example of what the performance skills entail, it is attention, searching, this is for brushing, so attending to the task, searching for the toothpaste, identifying their toothpaste, gathering their items, using them, organizing them, initiating them. On the other hand, you can see that for motor skill, it consists of positioning with or without an adaptive aid, which can be a wheelchair or a walker, or it can even be a stick or a crutch that they use to walk. Aligning themselves, reaching for the required items, grasping, stabilizing, manipulating, coordinating. So like this, there are different set of skills for each specific task, which have been altered according to the Indian population, keeping in mind the tasks which are applicable to most of the diverse population, because these things are performed by everybody in India or anywhere else in the world as well. Depending on, regardless of their occupation or their job or who they are or what they do. So yeah, that's all I wanted to share.
Thanks very much. We have a question from Jenny. Jenny said, thanks very much for the great talk. The question one is, how long does the FUMPS take to complete? And the second question is it easy to train others to deliver FUMPS?
Yes, so it takes right now, because I am doing the validation, it takes around an hour, 45 minutes to an hour, which includes taking consent from the patient, explaining the entire process to them. So because I'm doing the validation, I have to make them do 3 tasks. So it might depend on the tasks that they choose or the tasks that are most difficult for them to do, in terms of identifying the problems that they have. So it takes me around half an hour to make them. Again, it depends on the patient's level of functioning. If it's a client in RLA stage 4 to 5 or 5 to 6, it might take a longer time because they're a little bit more disoriented or they might be a little bit more dependent. However, if it's a client which is on a higher functioning level, maybe RLA stage 9 or 10, or maybe 8 or 9, it would take lesser time. Similarly with stroke or CVA, if it's a client with a good Brunstrom stage or good score on the Fugal Mayer in terms of their hand or their leg score, or their voluntary control, it takes a lesser time. But if it's a client which has more of hemiplegic presentation, where the weakness is more pronounced, or the muscles are not working enough, it might take a longer time. So overall, it takes around 45 minutes if you do it. Otherwise, it can be done within 30 minutes. For each task, it would take about 15 minutes. It is very easy to train because I got the feedback from all the therapists that have performed it. It does not require any specific training as compared to other tools that are present out there. So it is easily available as well. So it is easy to understand, it is easy to use, and it does not require formal training apart from what you might have studied in your rehabilitation degree.
Cool. Thanks very much, Stuti. Okay. Thanks again for your beautiful talk. I'm really looking forward to your work in the next step. And I think